Okay, welcome back. And Dr. Carlson, I'm sure will join us in just a second. I want to welcome everyone back to our webinar series and for ANAwareness Week 2021. If you've stayed with us, we are going to have Dr. Carlson and Dr. Deep with us again to discuss weight and scan. If you were new to this, I have a couple things I want to go over with you before we get started. Everybody who is on the call is muted. All of the attendees are muted, so you're only able to listen. If you have questions, go ahead and type them in the questions box. If you're on the webinar, if you're on Facebook, you can just type them into the comment section. You should see captions at the bottom of your screen. If you don't, you can click the captions button on the webinar. If you're on Facebook, you may have to adjust your settings. This recording or this presentation is being recorded and will be housed on our ANAwareness Week landing page on the ANA website. And it will also be on our Facebook page and in our video library. And we want you to visit the ANA or ANAwareness Week landing page to see how you can get involved in our exciting week. So you just go to www.anausa.org and click on the slider on the homepage to access that. So again, welcome, Dr. Deep and Dr. Carlson. Thank you so much for joining us today. We're going to talk about weight and scan now. And do you have slides that you'll be sharing?
Yep, I'll bring them up right
Awesome.
here.
Great.
Are they projecting okay?
Yep, they look great. Thank you so much.
All right, great. Well, welcome back for those of you who were with us in the previous hour. Today, we're going to go through, over this next half an hour or so, we're going to go through the natural history of vestibular schwannomas and the so-called weight and scan approach to management. I'm Matt Carlson. I'm one of the neurotologists at the Mayo Clinic in Rochester, Minnesota. There's 3 ear surgeons at Mayo Clinic in Rochester, and there's 3 neurosurgeons, and we all have a specific interest in managing and taking care of patients with vestibular schwannomas and many of the associated conditions that come with the diagnosis.
Nicholas Deep. I'm a neurotologist in Phoenix, Arizona, part of the skull-based team here. I also, with Dr. Carlson, share a strong interest in vestibular schwannomas, and from my standpoint, the surgical management that we do work as part of the multidisciplinary team, along with our radiation oncologists, neurosurgeons, neurologists. So thank you again for having us.
Just a shameless plug, if you're interested in reading a long book about vestibular schwannomas and probably more information that you'd ever want to have, there's a book online that's available through Amazon that we've authored. Dr. Deep is an author in the book, as well as many other people from the Mayo Group and elsewhere who talk about specific topics of their expertise. We also have a recent paper on vestibular schwannomas that was published in the New England Journal of Medicine. You do have to have a subscription to get access to the articles, but if you do, New England Journal of Medicine allows you to, if you subscribe for free, you can access 3 articles for free. And this provides, at least in my opinion, a good overview of the condition and different management options, et cetera. So the first thing, so we're going to talk about some common things that I think we all have heard before, and some of them are true and some of them are not. And so we're going to try to debunk some myths. It's a little bit like the show Mythbusters. And we'll go through some of those. And then in that vein or in that same context, we're going to talk about weight and scan. So just how common are these? So a lot of times when you acquire the diagnosis of a vestibular schwannoma for the first time, a lot of times initially you won't have heard of it before, but the more you learn about it, you might find that maybe even family members or friends or other people you've known have actually had them, which makes you think all of a sudden maybe they're a little bit more common than what us calling them rare all the time. So you'll ask your doctor, that's really kind of crazy. I got one of these. I won the bad luck lottery, so to speak. And so we'll commonly say, well, 1 in 100,000 people get these. And you'll say, well, that seems extremely rare. That statement's incorrect in the sense that that's an old estimate that comes from the 1970s, early 1980s, and the pre-MRI era, where it was difficult to screen people for the diagnosis. And then secondly, that's an incidence quote and not a prevalence quote. Not to get too much in the weeds, but when you say something has an incidence of something, you're talking about the number of new cases in a certain time frame. So like the number of new cases over a year. But it's not talking about the number of people who are on the earth that have it. Or another way to say it, how likely are you to acquire one of these if you live long enough? That's a prevalence question. And so if you look at the prevalence of the diagnosis, it's actually, if you live long enough, there's about a 1 in 500 chance in acquiring one of these. So all of a sudden it becomes a lot more common. So if somebody says, what is the chance if I live to the age of 70 that I'm going to be diagnosed with a vestibular schwannoma? It's actually 1 in 500, which takes you out of the bad luck lottery, and at least the bad luck Powerball maybe puts you in the back, the bad luck scratch lottery or something like that. So it's not as rare as people would once think. Just to say you're not alone in there, that kind of explains that, the large number of people that are cared for through the Acoustic Neuroma Association. There have been some changes over time that we've seen. Overall, it used to be that when you were in the pre-1970 or 1980, almost all the tumors were diagnosed at a very large size. And that's because CT scans aren't very good at detecting them until they get very big. And also our ability to screen for them, through asymmetrical hearing loss and audiograms and stuff weren't as good. But over time, with our ability to screen tumors better through better scans and screening for asymmetrical hearing loss, now patients are diagnosed with much smaller tumors with better hearing and less symptoms. So now it's pretty uncommon for a person to present with hydrocephalus at initial presentation. It definitely happens, but it's certainly under 10 or 15% of tumors that are presenting with hydrocephalus at time of diagnosis. So that's actually, it's good and bad. It's good in the sense that we're catching them earlier, and usually your outcomes are better when you treat a smaller tumor. But it's also more challenging in the sense that we have to be even more careful about our outcomes because we have to protect what you have, and you have more to begin with. And so it makes our job more difficult, and it's a good challenge. And it's something that basically all the innovations that we're looking at in surgery and radiation are meant to preserve those different types of function. How common are tumors likely to grow, or how likely is a tumor to grow? So if you're diagnosed with a small or medium-sized tumor, so just say something under about 1.5 centimeters in the angle, the chance of the old data would say that you have about a 10% or 20% chance of that tumor growing. That comes from the Danish literature. The Danish literature is a little bit different from ours in several different aspects. One is early on they use CT scans to document it, which is less sensitive. But also everybody in Denmark goes to the same center to have their tumors evaluated. So they don't have any selection bias, meaning everybody's going there. In the United States, we typically only get referrals for patients who are more likely to need treatment. Their tumors are a little bit bigger, but they have more severe symptoms and things like that. And so in the US data, the likelihood of growing is more than 10 or 20%. Depends on the study, but most people say that over the first 5 years, your chance of growing in the United States, your tumor growing is about 50%. So there's about a flip of a coin whether or not it's going to grow in the first 5 years of observation. It is true that if your tumor is going to grow, it's most likely to grow around the time it's diagnosed or in the first couple of years, but there are definitely cases where a tumor has been stable for a long time and then it will grow later. Some people will say, well, if your tumor hasn't grown for 5 years of observation, you no longer have to follow it because it's not going to grow. I think that's a incorrect statement, and we have plenty of cases that have demonstrated later growth. It's not common, but it definitely happens. And we believe that if you have a tumor that hasn't been, or essentially if you've been diagnosed with a tumor, you should, in most cases, have lifelong surveillance. You can increase the interval of the scan over time, but there shouldn't be a time where you say you no longer need scans, because that's usually when you end up in trouble, where you get late growth and you come back with a much bigger tumor, and your side effects from treatment will be greater because your tumor treatment was delayed. A more sensitive way of detecting growth is to detect the whole tumor volume. So that's detecting like how many drops of water would fill up that space. It's three-dimensional, it's much more accurate. What we typically do when we measure tumor sizes, we measure a single linear dimension. So we just measure it in one plane. So if you measure it this way, you might measure 6 centimeters or something like that. But what happens if the tumor grew this way? It grew more fat, but this dimension stayed the same. All of a sudden, it could be growing a lot, but you still don't call it growing. And so in that way, volumes are probably a little bit better to detect growth. If you use volumes and you follow tumor growth over time, you'll actually see that about 70 or 80% of tumors grow over time. Most of the tumors are growing pretty slow, but nonetheless, most tumors using volumes do eventually grow. This is, if you were here in our last talk, we use a similar type of graph, but these are called survival plots. It doesn't mean survival meaning you live or not. It just means survival of that symptom. So how long that symptom stays. So on the horizontal, you have years. So following from time 0 all the way up to 10 years. And then on the vertical axis, you have the percent of people who still have who still have not had growth in this case. And so if you follow people out to 5 years, about half of people have had treatment. About 60% of people have demonstrated growth on linear volumes, and even about 70% of people have demonstrated growth if you follow them volumetrically. And that's data from our group. I just want to demonstrate that, we don't have special data. Our data has been replicated by other groups, so it's not just our experience, but there is a lot of data or evidence to say that probably what we found is pretty similar, or probably true because other groups have found similar things. This just talks about the idea that if your tumor hasn't grown by 5 years, some people say you don't have to follow it anymore. We disagree with that statement. Having had a number of tumors that have exhibited late growth, we think you have to follow them over time. I want to mention this. This is a new idea. That's something that we've talked about lately. But the idea is that it's probably okay to watch a growing tumor if it's small to begin with. This is a very controversial point, but most people think the best chance of you staying the way you are right now tomorrow is to do nothing. So if you have surgery, you're going to change, things are going to change quick. If you have radiation, they're probably going to change faster than if you do nothing. So if your tumor doesn't grow, the best chance of you retaining your hearing the longest, the best chance of you not having worse dizziness, the best chance of not having facial nerve paralysis is probably just watching your tumor if it's small. So if you have a 2 millimeter tumor, a 4 millimeter tumor, which by all measures is small, it probably doesn't matter if it grows 2 millimeters. You probably still don't have to have treatment. So if you have a very small tumor, we're still even watching some of these. A very controversial thing. Right now, I would say that the standard or the most common recommendation is to treat a tumor once it's demonstrated growth. But there are certain select cases where it's probably reasonable to continue to watch it if it's small to begin with. And this just shows that this is another one of those survival plots. It just shows that if your tumor, so everybody in this group had one episode of tumor growth. And we looked at how long did it take for them to demonstrate another scan that showed growth. And this just shows that a number of people, after showing initial growth, it stopped growing for a while. And then they didn't need treatment, and maybe they had subsequent growth many years later. This is just volume changes over time. Just shows that some tumors grow fast and instead become steady. Some tumors shrink in size, only about 5%, but some shrink in size. And some will stay steady for a while, but then grow later. This is a last year. Kind of fun, something different. Dr. Deep, do you want to talk about the natural history of hearing loss over time?
I was actually just looking at the chat box. If you want to keep talking, I can answer some of these questions that are coming in.
Absolutely, glad to. So the other question about is, if you do nothing, what happens to your tumor? We talked about that. Half of them grow in about 5 years, and if you go longer out, even more of them grow. Typically, the growth rate is pretty slow. It's usually 1 or 2 millimeters per year when they grow. We typically watch tumors if they're less than about 1.5 centimeters. And just to say, most people in the United States are watching tumors when they're initially diagnosed if they're under 1.5 centimeters. There are some centers that will recommend upfront surgery to try to preserve that hearing. There are some centers that will recommend upfront radiation for smaller tumors, but most people at most centers are recommending an initial observation. If you take a giant group of people, 1,000 people, and your best chance at having most of those people maintain their existing function, it's unequivocal evidence that on average, watching it provides the best chance of keeping your function the longest. And so just to say that that's what most people are doing in the United States. People have been, we've done surveys and things like that to look at providers across the country, and that is the most common initial strategy. This just looks at your likelihood of losing hearing over time if you're watching your tumor. So even if this is a group of, this actually has 466 patients that had useful hearing at the time of diagnosis, and we followed them. Their tumor did not grow, and we followed their hearing over time. And so even if your tumor doesn't grow, your hearing is likely to decline over time. So that at 5 years, your chance of having useful, 5 to 7 years, your chance of having useful hearing is about 50%. And by about 10 years, it's only 40%. There's a very unique group of people that have 100% word recognition at time of diagnosis. So most people don't have that, but a small percentage of people do. If you have 100% word recognition at diagnosis, you are more likely to retain hearing longer. And it's somewhat intuitive in the sense that you have a more healthy cochlea and cochlear nerve. That's actually, that group of patients have a better chance of having hearing preservation successful with surgery. They have more likely to have hearing preserved with radiation, and they have more likely to have hearing preserved with observation. So that group, if you have a diagnosis and you have 100% word recognition in that ear, you're more likely to retain good hearing longer term. This just shows that if you develop hearing loss, like after your first and second scan, if you develop some level of hearing loss, you can actually kind of estimate how quickly you're going to lose your hearing long term. So if you lose more hearing between your first audiogram and your second audiogram, you're more likely to develop non-useful hearing faster than somebody who didn't have as much of a decline. So sometimes you can kind of pace a person's trajectory and understand where they're going to be long term by seeing how much they're losing in the short term. This is an awesome, I love this this graph or this page, probably almost more than any other page I've seen for vestibular schwannoma research. It's really cool. It's a way to personalize your likelihood of losing hearing if you have observation over time. So if you were recently diagnosed with a tumor, you can take your word recognition score and your pure tone average, and you can look at 1 year, 3 years, 5 years, 7 years, and 10 years. And for you specifically, your likelihood of maintaining useful hearing in that ear at those different time points. Because usually when we quote estimates, we say, you know, on average for a person, this is what you get. But this is actually dialed in for you individually, your likelihood of maintaining hearing long term. It gives very accurate counseling for patients. This is just some key points from this chapter of our talk. About half of tumors are treated after 5 years. About 70% of them exhibit tumor growth after 5 years of observation. You can demonstrate late growth, so don't stop getting your scans later on, even after 5 years. About 40% of tumors that initially grow might stop growing for a period of time. So if your tumor is smaller to begin with and you have really good hearing or something like that, it's not crazy to continue to watch your tumor, although I will admit that that point is very controversial and debatable among experts. And if you start to lose hearing early on in your path after your diagnosis, you are more likely to develop non-useful hearing down the road than somebody else. So that's kind of an overview of the natural history of a tumor that hasn't been treated. So that would be the wait and scan strategy, and also what might be anticipated for hearing in that setting. There's probably a lot of questions, and Dr. Deep and I would be happy to go through some of those. I know he's answered some in the text box too.
He did. Thank you, Dr. Carlson, and thank you, Dr. Deep, for answering those. Do you want to share the answer of the question that you just sent, or?
Sure. So there was a question about, a very good question, a 14 millimeter tumor, which is a 1.4 centimeter tumor, and asking, is it okay to continue watching this after 2 years of MRI surveillance with no growth? So 1.4 centimeters is on the upper limit of what we still call a small tumor. And the decision to continue observing versus treating is highly individualized. There's probably not a more controversial topic within neurosurgery than how to manage a small tumor like this, because it's a benign tumor. There's nothing that we can really do when it comes to treating tumors that's going to make you better. There's always going to be the risk of hearing loss, the risk of imbalance, the tinnitus that comes with the hearing loss. So, and of course, the risk of the facial nerve. So we're always trying to balance what are the goals for that patient? And again, there's not any individual, there's not one right answer. It depends on your goals. And that's why it can take, an hour-long discussion when we talk with you in the clinic about clarifying those, what's important to you. So the facial nerve preservation and tumor control, either with radiation, we're just trying to prevent it from growing, and with surgery, the goal of getting it all out, or at least everything out that's safe without jeopardizing the facial nerve function, is typically our main priorities. Hearing is usually the third rung on the ladder, and that's because, as Dr. Carlson mentioned before, in the vast majority of patients, over time, regardless of what we do, hearing tends to decline, whether it's the effect of radiation long-term, the effect of the effect of the tumor itself growing, and of course the effects of surgery. And so hearing, while it's important, it tends to take less priority compared to patients, compared to the facial nerve outcomes and the tumor control. However, let's say in your individual case, it's the tumor in an only hearing ear. Well, now hearing is catapulted to a very significant factor. And maybe we're thinking about, how do we preserve hearing long-term? A lot of that has to do with the age of the patient and their expected life expectancy. So these are some of the nuances that you have to talk with your team about as you sort of make that decision. If you're 30 years old and you have a tumor that's radiated, it's very likely that you'll lose hearing, let's say in 10 years, by the time you're 40. Or if you have a small tumor at 30 years old and you're able to undergo a hearing preservation surgery at a center that does a lot of that, well, it's very possible, there's no guarantees, but if you do save that hearing, you might actually hold on to that hearing for a lot longer. And for a young patient, that's going to be very meaningful, because the time that you have with that hearing is much longer compared to, let's say, a 70-year-old patient, where 10 years later, that hearing could really be, after radiation, could be quite meaningful, as opposed to losing it potentially instantly at the time of any kind of surgery. So age is an impact. The status of the other hearing ear, and how well they're hearing in the other ear, impacts our decisions as to whether we observe versus treat. So it's a very nuanced discussion. It depends on the patient's risk tolerance as well. Do you want to add anything to that, Dr. Carlson? Sort of a lot back.
Yeah, just because there's no randomized controlled double-blinded study, we don't really have the best evidence to support it also, but each treatment has its own pros and cons. And we always ask the patient what their priorities are, what they hope to get out of it. Some people can't miss work, but they feel like they need a treatment. And so they want something with the shortest recovery time, and that might be radiation. Some people might be a news anchor for a TV show or for a TV station, and they say, I cannot have facial paralysis. For me, that's the most important thing, and I want to have treatment. And so radiation might be the best thing for that. Other people might say, I've had a cancer somewhere else in my body. I really don't like the idea of having any tumor in my body, even if you're telling me it's benign. I just want this tumor in a different zip code. I want it out of my head. And that group of people might want surgery. Some people say, right now I have good insurance, and in 2 years I'm not going to. I want to have the surgery now. There's so many different reasons why people pick different things. And for that person, that was a very good decision, usually. Fortunately, we've looked at satisfaction after treatment. Fortunately, most people, there's 3 treatment options, but if you look at satisfaction after treatment, over 90% of people are satisfied with their individual treatment choice after their treatment. And so it's just to say that all of them can be very good for the individual person. Our goal is to give you what we hope is unbiased information about the pros and cons of each of them, and then you can decide which one best aligns with what you're trying to get out of the treatment, and we help deliver that. Our job is to give you the information. Sometimes people ask us, what would you do if it's you? But the problem is we're all so different, and what we need and what our immediate priorities are in life are different. You have a young mom that has 4 kids that can't stop picking up their kids. And so there might be lifting restrictions after surgery. I mean, there's just so many ways to think about all these things, and what each person how they think about it is completely unique and completely valid and different. So that's why there's not one best answer.
Okay, thank you for that. Can I ask you to stop sharing your screen so that just our faces are a little bit bigger than everyone can see what we're saying? Does anything change in patients where they have a sudden hearing loss, but then that hearing comes back, whether it's at full strength or even at a little bit of a loss? Does it change sort of how you determine and move forward?
I think a couple of things are worthwhile saying. The first thing is, of people who develop a sudden hearing loss, between 1% and 5% of those people have a vestibular schwannoma. So having a sudden hearing loss, you're still unlikely to have a vestibular schwannoma. But, right. The other thing is, of everyone who has a vestibular schwannoma, the likelihood of developing a sudden hearing loss during your journey is about 10 to 20%. So most of the time it's a slow progressive loss. Some people do experience a sudden hearing loss. There's this idea that if you experience a sudden hearing loss and you have a vestibular schwannoma, you don't need to get steroids because the problem is the tumor. But oddly enough, we found that steroids do seem to help those patients as well. So if you experience a sudden hearing loss, and it's a real hearing loss, it's not where you say, oh, it's just a little bit different and your hearing test says it's about the same, but a pretty big loss, or, a loss. The general recommendation, at least in my opinion, and probably Dr. Deep's too, is to get a steroid treatment. And it can either be an oral steroid, or it can actually be an injection in the ear canal. You'd say, well, how does an injection through the eardrum of a steroid help the nerve? Because it's not even by the nerve. But oddly enough, that probably does help too. It might be some inflammation in the inner ear from the tumor. So if you have a vestibular schwannoma and you develop a sudden hearing loss, our recommendation is to get steroid treatment. And I'll say that's a little controversial or a misconception in the general medical community. Sometimes people won't offer it. But if you do recover hearing after a sudden hearing loss, there is some thought that you have what we call threatened hearing. It means your inner ear is more unstable than somebody else who hasn't acquired that. And so sometimes people will make an argument for going for it, going for the hearing preservation surgery in that situation, or even going for radiation. It's usually in the context of going for it for surgery. You're saying, well, you want to try to save that hearing because after the hearing's gone, and if it doesn't come back up, you can't get it back with surgery. So the answer is nobody knows. There's actually no data that says that if you have that sudden loss, it's better to try to sudden loss that recovers, it's better to try to intervene to try to preserve it. We actually don't know. But if somebody made that argument, I think it's probably a very valid way to think about it. It would be also reasonable to watch it. Your risk of developing a subsequent sudden hearing loss is higher if you've already experienced one, although I'm not sure of any literature that supports that either.
But that's sort of my thinking too. And again, there's not really good data to prove it, but if I see a patient with a hearing loss, a sudden hearing loss that, recovers with steroids, it's a fragile ear. The hearing is sort of teetering on the edge and it's about to start going down. If the tumor is small, it might be worthwhile to continue watching it because you're buying time with this useful hearing. And then once the hearing does go out and doesn't respond to, let's say, a subsequent dose of steroids, then you can move forward with treating. And once the hearing is out of the equation, it can very well help us make decisions because we're not thinking about preserving hearing. You have less to lose. And so maybe that's the one thing that was steering you away from doing surgery was preserving your hearing. And now that the hearing is gone and not coming back, it makes the idea of undergoing surgery, a lot easier. It clarifies the whole decision process. But I do think buying time with useful hearing is an important goal. And so for small tumors that are fluctuating with hearing, I would probably just continue to watch them.
Okay. We talked about making sure that you're following up, even if you don't see growth in your tumor for a certain length of time. You want to make sure that you continue to follow up and continue to get scanned. But there's some question as to the use of gadolinium in MRI scans. So if you're doing follow-up scans over the long term, is it okay to do, use MRIs without the gadolinium and the contrast solution just to avoid that issue?
Yeah, absolutely. In fact, it's my preference is to, if we're just we're looking at either following an observed tumor or a tumor after surgery that was subtotally resected or a tumor after radiation, we just do I get an MRI of the brain without contrast, and I ask the radiologist to do what's called a KISS or Fiesta sequence. It's a type of sequence that gives us very fine detail and allows us to see the tumor, but without the use of contrast. Mm-hmm. It's important we get the contrast in the first place. You might ask, why are we getting contrast in the first place then, if we can just do this? Well, it's important to confirm the diagnosis. But once the diagnosis has been confirmed with either that first MRI or repeat MRIs, we don't need to confirm it with more contrast. We can look at it in the other sequences on the MRI.
Okay. I don't honestly know if you can tell the makeup of a tumor if it has a cystic component from an MRI. But if you can tell that, does that change your determination as far as how to proceed, whether you continue to watch or if you would move forward with treatment?
Yeah, cystic tumors are very controversial. There's some people who feel very strongly one direction about some of the treatments, and there's some people that feel the other way. And I can just talk about some of the nuances of that subject. So the first thing is to say that almost all vestibular schwannomas have cysts in them, but most of them are microcysts. So they're just small. It's a heterogeneous, meaning that it's a little irregular on the scan. When we talk about cystic tumors, we're typically talking about where they have larger water balloons. And most studies would say that a truly cystic tumor is where the water balloons comprise or make up about at least half of the total tumor size. So when we're talking about cystic tumors, that's usually what we're talking about, ones with very large fluid cavities. There's two types of cysts, and we're going to get into a lot of detail, but there's a central cyst that's in the middle or in the meat of the tumor, and all around the outside is firm tumor capsule. Those are basically the same to remove and maybe even radiate because it's in the center of it. There's another kind where they grow on the periphery, on the outside of it, and then you just have this thin translucent membrane that's a little bit more challenging to remove and dissect off of things. With surgery, most people say that if your tumor, so actually let's just back up. With observation, a cystic tumor is capable of growing faster than a non-cystic tumor. Those cysts can grow very quickly, but they don't always. So just having a cyst doesn't mean you can't observe your tumor by any stretch, but you might watch a little bit closer. If it does grow, it could grow faster than a one that's more solid. The second thing is you talk about risk of surgery with the cystic tumor. Some people will say, all a cyst does is makes my job easier because half the tumor is just water and you get in there and you open it up and half of it's already gone. Other people say it's that really thin membrane that's harder to dissect off of things and you're more likely to leave a little tumor capsule. So that's controversial. Most people say it's a little more challenging, but there have been people that say there's no difference. Then the last thing with radiation, there is an old feeling that radiation is not effective against cystic tumors, and that would be a relative contraindication because it doesn't treat that cyst wall effectively. I would say most of the time people still feel that way, but there actually is a lot of good newer data, including data from our center and several other centers that say radiation of cystic tumors actually is effective. You probably have to follow them closely to make sure they don't rapidly expand, but there are many cases where they have stabilized or even shrunk cystic tumors as well. So I think the more we learn, the more we realize we were wrong a while ago. It's just more pieces of the puzzle, more information.
Okay. You also mentioned in your presentation volumetric measurements. So are there tools available to people? Are they able to look at their scans and figure out somehow this volumetric measurement, or is it something that just physicians use? It's not as common. We don't hear it as much, although we are starting to hear a little bit more about it, and we've heard the same, that it's a little more specific when you're looking at growth. But as far as patients are concerned, how can they gain that knowledge?
It's a great question. There's a lot of discussion that you could have just around the topic of volumetric versus linear size. So there's a lot of different ways you can measure a tumor size. Mm-hmm. Most commonly, we measure a single diameter. Like the Academy of Otolaryngology recommends measuring it in two perpendicular diameters in the axial plane, so the level, this sort of plane on the head. In your most measurements, you're only supposed to include the ice cream scoop and not the cone. So we don't include the internal auditory canal portion when you measure it. So you'll see one provider and they'll say you have a 1.8 by 1.2 by 0.6 centimeter tumor, and you'll go somewhere else and they'll say, no, it's a 2.0, and they're looking at the same scan. They're both right and they're both wrong. There's so many different ways to measure it, even though they're looking at the same thing. Then you also have to make sure you don't mix up millimeters and centimeters, because that's a very big difference between the two. But just talking about volumes, most centers are not measuring volumes for clinical purposes. So if you come into our center, we're still not using volumes to measure your tumor for a couple of reasons. But most importantly, it's not practical. It takes a lot of time to actually do that. And when you're seeing a large number of patients in clinic, you just don't have that time to bring it up. And we call it segmentation, where you individually trace every single scan and use it. So the reason why 99.9% of centers don't use volumes is just because, practically speaking, it's difficult to do and implement it into clinical practice. There is a system called semi-automated segmentation. So you can trace some of it and then the computer can kind of fill in the rest for you. So it makes it faster. There's a lot of work around artificial intelligence now. So using computer systems to do a lot of the work and offload work from the physician or whoever. AI is used in a lot of different areas. So I think in the future, more centers will have an automated segmentation where the computer does everything and it spits out a number. So I think in the future it'll be used, but it's unquestioned. It's definitely not a mainstream thing right now. A lot of people who don't, so volumes are really helpful, particularly for research, because the tumors grow so slowly. It's helpful to detect very small differences in growth, particularly if you're looking at medication uses or something like that. Some people will say, I don't like using volumes because if I can't see that it grew on a linear size, that growth then doesn't matter. So you could say, well, you can detect it with volumes and you can't detect it with linear yet. But if the change was so subtle that I can't even see it, then it probably doesn't even matter. And I think that's a reasonable consideration. But if you're really trying to dial in, when does something really starting to grow, volumes are more sensitive. Probably a much longer answer than what the person wanted, but that's how we kind of think about it.
Very helpful. So for patients who are post-surgery or have been treated and had surgery, but there is some tumor remaining, would you treat that? Generally, it's usually a small, very small bit. Would you treat that the same as you would a small tumor as far as observation is concerned, or does that need to be treated in every case?
So depending on the amount of residual tumor and also the time after surgery. So sometimes we leave a little carpet of tumor on the facial nerve to preserve the facial nerve function. And oftentimes that little carpet of tumor has been so devitalized, it doesn't even grow. So even though we've left some, we haven't left enough to allow it to keep growing. And over time, at our 6-month or annual MRI, we don't see any growth. So even just seeing it on a postoperative MRI, I don't get too excited about. If I see it start to grow on future MRIs, that's when we discuss further treatment. And again, that conversation can be very nuanced. It is a discussion with the patient as well as our team. In terms of how old the patient is, how fast it's growing, how much tumor we're talking about. Oftentimes, though, it's recommended to do a one-time dose of gamma knife radiation to halt that tumor growth. That's probably the most common management of residual tumor growing after surgery.
Okay, yeah, this patient was very young, like in her 30s, and that's what they mentioned, and we're wondering about that. Let's see, what was the other question I was going to ask? So you mentioned that that there are that the incident or the prevalence, I might have that wrong, the prevalence of the tumor is much higher than what the 1 in 100,000 that we have been looking at for years and years. So if someone has a hearing loss, should they go ahead and have a scan just in case if it's that common?
Great question. So if you live long enough, you will get hearing loss. There's a lot of risk factors for hearing loss: family history of hearing loss, noise exposure, recreational or occupational, and then just being on this earth longer than somebody else who's younger than you. And all of those things contribute to hearing loss. Those are the most common causes of hearing loss in the United States. Just like your left leg is about as long as your right leg, and your left arm is about as long as your right arm, your hearing in your left ear should be about the same as your hearing in your right ear. And if they're different, you say, why is that? And sometimes it's just, we don't know why, but it is the cause, and there's nothing else that we can identify. But in some cases, when you have what we call asymmetrical hearing loss, one ear is worse than the other, there ends up being a tumor there. So if you have hearing loss and it's equal in both ears, based on an audiogram, not just your perception, but based on an audiogram, then we usually don't get an MRI. If there is a difference between the two ears, then we usually do get an MRI. And that's one of the reasons why the disease prevalence is more common now, because people are looking very closely at asymmetry in an audiogram to get an MRI scan, which will lead to your diagnosis. How much difference qualifies as being significantly different to get a scan? Is it just, one frequency off, that sort of thing? How much do you have to have different? Most people say at least 10 decibels in two adjacent frequencies, or at least 15 decibels in a single frequency. Some people think the most sensitive frequency is around 3,000 hertz. A lot of information more than you want to know, but basically if they're different, you get the scan. Difference in word recognition score is a little bit more tricky because it depends on where you are, how much loss you have for it to be different, statistically significantly differently enough. But basically, if you have about 15 or 20% difference between both ears with your ability to understand words, we typically get a scan as well. But it's important to say that only when you get a scan for a sudden hearing loss or asymmetrical hearing loss, only about 1 to 5% of people still have a tumor there. So most people don't, but it's high enough where we recommend getting the scan.
Okay. And you talked about studies in Denmark and how they track sort of their numbers and everything, and then that it's different in the United States. Is there a national or centralized database of diagnoses of acoustic neuroma in the United States?
There is not. So in Denmark, so a lot of countries that have government-run insurance programs often have centralized centers of excellence for different things, particularly for smaller countries. And so in Denmark or in the Netherlands, or there are other examples of places like that, if you have a specific diagnosis, you only go to one center and they can catalog and archive all of the patients who have come through there. So in that way, there's really no selection bias. There's a 100% capture rate. In the United States, there are some population databases. Most of them, the most common one is the SEER database. The SEER database captures about 28% of the US population. To get accurate data, you either need to do one of two things. You need to survey everybody, or you have to survey a population, a sample population that represents everybody. Those are the two ways you can only get pretty accurate information. And a lot of people think the SEER database is representative of the general population. There's also another brain tumor registry that's used. The problem, we've looked at that specifically, and the problem with those registries are they are made to capture cancer diagnoses. And so most cancers undergo radiation or surgery. So if you have observation, those registries actually miss a very high number of people who haven't had treatment and they're just getting surveillance. And so they don't provide accurate demographic or epidemiological estimates like we just talked about, the prevalence and incidence. There are some small scale population registries that do capture everybody in that area. And Rochester has one. In 1966, a neurologist developed what we call the Rochester Epidemiology Project, and it captures every single care episode in Olmsted County, not just at Mayo Clinic, but also Olmsted Medical Center and any other smaller clinic. And it's a linkage system that puts it all together. So we can, in that way, we can capture everybody that had treatment here, if they're from here or elsewhere. And that's helpful. That's how we came up with a lot of our estimates of the 1 in 500 people, things like that. There's also one like that in Utah. So Utah has a very unique, I think it was a state-run population registry. And there might be a couple other examples, but we don't have a national registry that captures everybody like they have in Denmark.
Okay. Okay. For patients who have acoustic neuroma, who've been diagnosed, and they have some family history of hearing loss, like with their parents or siblings or something, would you recommend that they move forward with treatment? Not necessarily, but does that change how you approach the tumor and what you do with it?
So you're asking if a patient has an acoustic neuroma and they have a family history of hearing loss?
Yeah, so it would potentially losing hearing in the hearing ear, or the ear that would have better hearing, or the non-AN ear, I guess.
Right. So there's a whole host of genetic type hearing losses that we're only scratching the surface in terms of learning about as we learn more about, expand the field of genomic medicine. So having a history of hearing loss in the family, let's say less than the age of 50. And there's some classic patterns that your ENT can kind of point you to that may suggest a congenital or genetic type hearing loss. But if you have that, we would call that a threatened ear. And so then if you add on to that acoustic neuroma, so now you have two reasons to have a threatened ear in the acoustic neuroma ear, and the other ear is also threatened. And so this is another one of those examples of where I mentioned before, the hearing is sometimes our third consideration after tumor control and facial nerve preservation. In these patients, the hearing can be bumped up to one of the more of the chief concerns oftentimes for those patients. It sort of depends again on what the level of hearing is at that other ear, how quickly it has dropped off over the years. Getting annual hearing tests, even if you don't have hearing loss, but you have a family history of it, I really recommend those patients get a hearing test to establish a baseline. Some patients have had some congenital hearing loss and they don't even realize it. So they don't even know that, compared to their peers, they have some hearing loss, but this is all they've ever known. But if you were to get a hearing test and objectively look at it, we could say that, oh, you actually already have some hearing loss, but they're not really aware of it. So those patients have to be monitored very closely. And the decision-making in terms of treatment is very nuanced. Again, for those patients, similar to the NF2 patients, it's all about buying time with useful hearing. And that's really the focus. And so again, most of our strategies are not gonna improve the hearing. And so perhaps for those kinds of patients, we take more of an observational approach, so long as the tumor is not large and causing other types of potential complications. But as long as it's on the smaller side, my bias is to be more conservative and observe those.
Okay. This is a question that asks a question about some symptoms that are different than hearing. When you have patients who are on the wait and scan approach, how often do you see facial numbness or a salt taste or a difference in taste in those patients? Is that something that you commonly see prior to treatment?
Those are good questions. For wait and scan, dysgeusia is that metallic taste or something like that. There's a nerve called nervus intermedius, also called the nerve of Reisberg. It's called intermedius because it's intermediate between the facial nerve and the cochlear nerve at the brainstem. That carries it carries the fibers that give you tearing in your eye and development of mucus in the back of your nose. So that's why you can get dry eye. But it also carries the taste fibers to the anterior part of your oral tongue. And so a lot of people will notice taste changes. It's uncommon, but not impossible to experience those symptoms during observation. The risk is certainly highest to experience those with surgery, and your risk is kind of intermediate with radiation. But that's the that symptom is most common after treatment with surgery. I'm sorry, the first question was, you asked about taste change. What was the other one?
And facial numbness.
Oh, sorry. So facial numbness, almost always, not always, but almost always is related to the tumor growing to us. So there's 4 nerves that do 3 things that are always touching a vestibular schwannoma. There's 2 balanced nerves, 1 hearing nerve and 1 facial nerve. There's never been a vestibular schwannoma that wasn't touching the facial nerve. They're immediate neighbors to each other. The 5th nerve is a little bit further away, and the tumor has to grow to a certain size before it touches the 5th nerve. The 5th nerve is what gives facial numbness. Most commonly, people experience it around their mouth first, but then they can experience on their whole side of their face. And less commonly, that nerve of facial sensation can also cause facial pain. We call that trigeminal neuralgia from having the tumor pushing on the nerve. In most cases, a tumor has to grow larger than 2 centimeters for it to cause that. We've always, you never say always or never, or else you're setting yourself up to be wrong pretty quick. But in general, a tumor has to be over 2 centimeters to start causing facial numbness. We generally don't watch tumors that are about 2 centimeters in size. So on average, a person in observation won't have numbness, I guess is how I'd answer that, but it's not possible.
So it's not common. Okay. What about, so we have a question here from a younger patient who has a very, like a 9 millimeter vestibular schwannoma. And she's asking about the most important questions that she should ask her ENT and her doctor and her, anybody to go forward with treatment.
Just a couple of quick questions. Sorry, approximate age?
32.
And how is the hearing? Is the hearing good in that ear? Or?
I don't know that.
Sorry, if the hearing is really, so in somebody who's 32, usually when you're under 30, you worry just a small bit about a person actually developing a tumor in the other ear. Most people don't, so I don't want people to be on here to be scared about it. But if you're under 30, and particularly if you're under 20 and you develop a vestibular schwannoma in one ear, there is a small elevated risk of having it develop in the other ear. So we always think about that. You always ask about family history, if anybody else had any neurogenic tumor, schwannoma, anything else of the sort. But then if it does turn out to just be the unilateral one, like most people have, then I know you say, what's the most important questions to ask us? I would actually say the most important questions are ones we would ask you about what's most important to you. Again, is some people say, I'm the youngest and I'm the healthiest I'm ever going to be. I just get this thing out and give me the best chance of cure. That's surgery, but it does place your hearing at risk up front. Some people would say, I want to be the most like I am now for as long as possible. That's doing nothing. Some people would say, I want treatment of it, but I don't want to go through all the recovery and the slightly elevated risk with surgery. Then maybe radiation is good. In general, we don't radiate a non-growing tumor if it's smaller. So if your tumor is less than about 1.5 centimeters, we don't radiate it unless it demonstrates growth, because as we talked about earlier, about half of them grow, half of them don't. And the goal of radiation is to make it not grow. So if you radiate a tumor before you knew it was growing, you may not have needed that treatment to begin with. If the tumor is over 1.5 centimeters or so, and under 2.5 centimeters, you might actually consider radiation without knowing it's growing or not, because it's already at that size where you don't want it to grow too much more. So some people will do upfront treatment with radiation if it's a little bit bigger, but you specifically asked about a 9 millimeter tumor. We usually wouldn't do upfront radiation with that, but it would be something that would be offered if it was growing. I would say if you pulled every single person in the United States who was 32 years old, who had very good hearing in one ear and no issue with hearing on the other side, and they saw 1,000 different experienced providers, 90% of the time you would start with observation, 80 to 90% of the time. But there is some differences of opinions and differences in priorities of the patient. So it's heavily driven by what the patient wants and what they're hoping to get out of the experience.
One thing I just want to add to that is, especially for younger patients, if hearing is a big concern, because you're young and the risk of the tumor taking the hearing either through observation, radiation, or surgery, it's very likely that in the long term that hearing is going to go down. So for a younger patient, we can think about this idea of cochlear implantation that I spoke about before in the previous hour. But the caveat being a cochlear implant only works if you can preserve the cochlear nerve. Now for tumors, and this is somewhat controversial, but it really has to do with, probably most of just the experience of the surgical team. Tumors that are above 1 to 1.5 centimeters in size, it becomes harder and harder to actually save a viable cochlear nerve. So this is a controversial and sort of a ongoing management philosophy. But if you're thinking about cochlear implantation for hearing rehabilitation in the future, which again is going to be more significant for a younger patient who can benefit long-term from that, Well, intervening before the tumor becomes usually, more than 1.5 centimeters in size, measured in the angle, not in the long axis. So measuring the ice cream cone portion of the tumor, more than 1 to 1.5 will increase your odds of the surgeon being able to remove that tumor while also preserving the cochlear nerve as well, to make a cochlear implant an option for you down the road. But again, this is another one of those facets of that conversation that you have with the surgical team. And so that can also dictate when to intervene as well.
Okay, great. Well, we are getting to the end of our time here. Is there anything else you wanted to add that you wanted to touch on or address based on questions you've seen? Or I feel like we've covered a lot.
I think, speaking for Dr. Deepy and myself, we're very grateful for your time, and also Melissa for you coordinating all this. The ANA is such a tremendous resource to acoustic neuroma patients across the country, and even from the provider side, a great service. We've received some research support from you, both through surveying a lot of the patients, but also even developing a quality of life inventory. So, hats off to you for putting money out there to support initiatives to make patients' lives with acoustic neuromas better. This was talked about yesterday, but I think the first thing to do for when you receive a diagnosis, particularly if it's not a large tumor, is to take a breath, and you have time to think about things. It's not an urgent thing. And there's a lot of data that says that, the worst day of your diagnosis, of your journey with your tumor, is the day you were diagnosed. And it can get better after that, because you can start to understand it's not a death sentence. There are some consequences of it, but a lot of it can be managed pretty well. I'm not trying to say it's not a problem. I definitely understand that it can significantly impact people, but just to say, if you can sit on it and think about it and get more information through the ANA and visiting with several providers that can give you different opinions about it, and discussion or talking to previous patients, you should do that, because it's not an emergency in most situations, and just taking a breath and a pause and approaching it cerebrally and thinking about it is beneficial.
Thank you. Thank you for your time today. Thank you for the presentations. Thank you for answering all these questions. We are so grateful for our relationship with you and for your partnership in helping us serve patients and do what we can to support and educate and do everything we can for them. So that is it for our presentations today. Tomorrow, we'll be talking about eye issues. There is a chance that the time of that presentation is going to change. So watch our social media and website for that information. We're also going to talk to Dr. Driscoll and Dr. Link about surgery, and then Dr. Price about facial reanimation. So those will happen tomorrow. Go ahead and visit our website at www.anausa.org and just click the slider on the homepage. That'll take you to our ANAwareness Week landing page, which has the complete schedule, and that will be updated as soon as we have the correct information. Again, Dr. Deep and Dr. Carlson, thank you so much for taking the time today. We really appreciate it.
Thank you.
Thank you.
Have a great day.
You too.